Right. Redefining comfort in modern palliative care. So today we are going to discuss about a very important topic based on a clinical case. Uh, why I'm telling this is very important is any clinician who is dealing with patients with life limiting illnesses, uh, first to encounter is the main problem is this problem, that is family collusions. So how we should know how to manage family collusions, and this is the first challenge as a clinician we are facing. And during this lecture I will talk about how to manage this challenge with confidently and competently. So, a clinical playbook for managing family collusions. Now, the clinical history is a 50-year-old male patient diagnosed with a pancreatic cancer, status post Whipple surgery 4 years ago. And after that, he had 12 cycles of adjuvant chemotherapy, FOLFIRINOX. And after that, he was on follow-up, and now presents with a dry cough, right? Dry cough, shortness of breath, and loss of appetite, and back pain. And to find out why these problems are there, the clinician has done a computer tomographic contrast enhanced scan, chest, abdomen, and pelvis. Unfortunately, that reveals multiple bilateral lung metastasis and multiple liver metastasis. So this is a stage 4 recurrence of a pancreatic cancer patient. Initially, we thought it's curable, and he had disease-free 4 years of survival. So this patient presents to the clinic, and his wife and the daughter, daughter, and his best friend, actually, who is always with him during his difficult times. So all three of them brought this patient to the clinic. When their turn came, they entered the consultation room, keeping the patient outside. And they humbly request the clinician not to tell anything related to the disease to the patient, right? Please do not tell him anything related to the disease. He may not tolerate the bad news. So the family knows what's going on, and they are requesting the clinician not to tell anything about the disease. And this is not because, the outside the clinic, the patient is sitting and he's experiencing severe dry cough, shortness of breath, and back pain. And you can imagine outside the clinic, sometimes there are name boards, right? Cancer clinic or palliative clinic. All these things are there, and there may be other patients. Some patients may be while undergoing chemotherapy without hair. So, even though the background says something, environment says something, the family members, they are requesting not to tell the truth. And so they are expecting to be done everything without patient knowing the truth, like that. So this is the first challenge. Many of the clinicians, I hope all of the clinicians must have faced this situation. I'm experiencing every day. What the family members are telling is he is very weak. He can't even tolerate a simple, even a small bad thing, right? He get upset. So this is the story. How do you manage this thing? Now, the anatomy of family collusion. Now, collusion refers to a secret agreement made between clinicians and the family members to hide the diagnosis of a serious or life-threatening illness from the patient. So this terminology is used for that, right? Actually, unfortunately, in Sri Lankan setup, most of the time this is happening, right? This collusion, family collusion is happening, and the clinicians are also working according to that. I mean, they accept that. So the family motivated by protective love. I mean, they are not trying to do any harm to the patient. So they are motivated by protective love and fear of causing emotional harm to the patient. So they are surface. I mean, what they are doing seems to be a good thing to the patient. And clinical standard is withholding a diagnosis explicitly violate patient's autonomy and creates a barrier to essential care. So, how can a patient uh, take the decision of a treatment, taking treatment or not taking treatment, or what sort of treatment they should take? How do they decide that without knowing the condition? Now we know it's a basic principle that we have to respect the patient autonomy, especially when the patient is having the capacity to take decisions. So if the patient is having capacity to take decisions, uh, how can this patient take decision without knowing exactly what is happening around him? So this is the clinical standard now. So family wanted to hide the truth, and we are in a big difficult situation now. So this barrier isolate the patient who likely already suspect a recurrence due to severe systemic symptoms. So at this situation, even though the family thinks that patient doesn't know anything, with these difficult situations and looking at the surrounding environment of the clinic, so patient may be suspecting a recurrence situation at this time, right? So, so the paradox of collusion. Now, families perceive benefit. Now, we are protecting him from emotional pain, right? We are protecting him from emotional pain and despair, right? So, uh, if he doesn't know, he can continue to live normally. So, patient's side, the family side, they are thinking that uh, we are actually protecting the patient without, I mean, protecting the patient from getting emotional pain, right? And they think that patient might be able to continue a normal life uh, uh, without any problem without knowing this condition. But actually, what will happen? Patient's clinical reality is what? He is already suffering terrifying physical symptoms entirely alone. I mean, dry cough, others can hear, but they are not suffering. No? I mean, they are not experiencing it. Severe backache, loss of weight, all these things, genuinely, the patient is suffering alone, isolated from those who love him most. So he can see others are trying to help him, the family members are moving around, but the suffering is for the patient in this situation. But he has to withstand this suffering alone. So he is locked out of advanced palliative oncology care. So without, I mean, not allowing the patient to know the truth, so what will happen? He will be locked out of advanced palliative oncology care, right? Clinical trials, I mean, in developed world, most of these patients put into, incorporate into clinical trials. So he will not be able to get that chance. And symptom relief due to lack of information. So he will not be able to relieve his symptoms because he will not be able to give the informed consent. With having the capacity to take decision, he doesn't know what is happening around him, and without his informed consent we can't treat him, we can't help him. So he will be locked out from all these facilities by without knowing what they are doing because of the family decision, right? So this is the paradox of collusion. We think that we are doing a good thing, but actually what is happening is a very bad thing. So there is an empathetic blueprint to navigate collusion. I mean, you can't tell the family members you are doing a wrong thing. Legally, we are bound to tell the truth to the patient. So if you don't tell the truth, even patient can go to the court and take legal action. So that sort of legal things, too much technical things we can't mention at this situation because family members are genuinely trying to help the patient. They are also emotionally down. So first thing what we need to do is we should listen to the family members carefully, patiently, and we should validate and explore the family's fears. That is the first step. The second step is educate the family on risk of non-disclosure. So we will come into in detail how we are doing these things. So we have to educate the family on the risk of non-disclosure. What is the risk if you don't tell the truth to the patient? Negotiate an agreement to assess the patient. So after that, after telling the risk, you can negotiate with the family members to assess the patient. Come to an agreement to assess the patient. So that is the negotiation part. We have to be careful on this. We're using all the communication skill techniques. You have to do this thing. Then bring the patient inside the consultation room and deploy the spike protocol. So that is the standard protocol to do a communication, this sort of communication. And then after that, you can offer multidisciplinary palliative support to this patient. So without breaking all these barriers, it is very difficult to help the patient with full scale.